Patients come in with all sorts of different levels of experience and knowledge. Some have read about it for a time. For others, it's really new. I mean, yeah, it's hard to generalize that particular situation. But if patients are coming in with the notion that well, many patients come in with the notion that I'm going to die in the next 6 months because I have a stage 4 cancer, and that's obviously not necessarily the case with this disease. So in many cases, there's a reassurance that the situation may not be as bad as it has seemed at the outset, but it varies quite a bit. I mean, there are patients with this disease who do have a poor prognosis, unfortunately. So everyone's very different, and it's hard to overestimate how heterogeneous neuroendocrine tumors are. Stage, grade, differentiation, hormone production. I mean, it's not one cancer. It's a huge family of cancers. So I'm not a nuclear medicine doctor, but my understanding is that each scan is somewhat variable as far as what the individual scan is. So it actually is hard to translate a precise SUV from one PET scan to another, although the range is probably not huge. It's actually useful to compare to the normal liver. So usually the normal liver, just ballpark, would be an SUV range of say 4 to 10. Meaning that twice the normal liver would be somewhere from 10 to 20. These are just ballpark numbers. So carcinoid tumors can produce symptoms either by virtue of the tumors themselves, which can cause bowel obstruction, can cause pain, weight loss, nausea, depending on location, and then they produce hormones in many cases, like serotonin, and so the carcinoid syndrome primarily consists of flushing, which means redness of the face, upper abdomen, warmth, and diarrhea. Those are the main symptoms. Patients eventually can develop carcinoid heart disease, which gives you shortness of breath, leg swelling, things like that. That's a tough one. So it sounds like someone who's going to have debulking surgery. Debulking surgery rarely takes up all the NETs. Usually once you have metastatic disease, there's at least microscopic disease left behind, although if you're lucky, I think they can remove all gross visible disease, then that's obviously a good thing. If all visible disease is removed and you have carcinoid syndrome, likely you will no longer have carcinoid syndrome after surgery, at least for a period of time. So I would say that immunotherapy as a whole has been relatively disappointing for neuroendocrine tumors. Certainly with single agent PD-1 or PD-L1 inhibitors like pembrolizumab. There was very preliminary data from a study, the so-called DART study, that looked at the combination of ipilimumab and nivolumab, so a combination of 2 immunotherapy drugs in poorly differentiated high-grade neuroendocrine carcinoma showing a high response rate. But there's a lot of caveats. It was a tiny number of patients. It wasn't a pre-planned subgroup analysis. It was an interim analysis. So we're still waiting for the final data. In the end, it'll probably turn out that the overall response rate is lower, but there is some activity. And in a disease like, especially poorly differentiated neuroendocrine cancers, where there are very few treatment options, there will be some patients who have long-term remission, and so it's probably worth trying. But the response rates are going to be quite low, I think.